Welcome to the Health Workforce Technical Assistance Center's webinar series. This webinar is entitled The New York Delivery System Reform Incentive Payment Program, Reducing Avoidable Hospitalizations. And it was presented by Peggy Chang, Tracy Leonard, and William Meyer on March 13th, 2019. Hello, my name is David Armstrong, and today's webinar focuses on the New York DSRIP program. Our presenters are Peggy Chan, Tracy Leonard, and William Meyer. Now, after today's presentation, you may ask questions using the chat panel on your screen. Also, when the event ends, you will be directed to a short evaluation survey. So please take a few moments to provide us with your feedback. And with that said, I'm going to turn the event over to our first presenter, Peggy.
Good afternoon, everyone. This is Peggy Chan. I am the DSRIP Program Director for the State of New York, and you'll see on this first slide that what DSRIP actually stands for. It stands for the Delivery System Reform Incentive Payment. And really, this is a major initiative that New York State undertook that was available from the federal government as a Section 1115 waiver in terms of doing a demonstration program. So let me advance the slide. Yes, it advanced successfully to explain to you more about that. So back in 2011, after Governor Cuomo was elected, New York State's Medicaid system was found to be really last in quality and the most expensive in the country, according to a Commonwealth Foundation report. With that, there was a statewide effort to understand how we could improve the Medicaid system into one to improve the quality and to also make it financially sustainable because it was not on that path, at that point. Basically, through a statewide stakeholder process, many opportunities were identified for improvement, to improve care, improve quality, and to contain costs and provide that in a much more accessible way to our low-income citizens. So out of those recommendations, many initiatives were implemented, and out of that came savings. For Medicaid, not only is it saving the state dollars, but because of the federal match to Medicaid, it also saved federal dollars. In that vein, New York State petitioned CMS to ask that some of the savings for the federal government be reinvested in New York's efforts to continue the transformation and to put it on more solid footing. So with that, the CMS granted the state a waiver that allowed the state to reinvest $8 billion of the $17 billion in savings, and $6.4 billion of that went to the DSRIP program. So under that, really, our goals here are to transform the state's healthcare system, bend the Medicaid cost curve, and assure access to quality care for all Medicaid members. And I'm glad to say that we are on a good path thanks to the efforts of people like Tracy Leonard and Bill Meyer, who will be presenting after me. So when we talk about what the overall goals of the New York State DSRIP program, you'll see one of our ambitious goals was to really reduce avoidable hospital use by 25% over 5 years. And, and what I should explain is that these payments are not to pay for services that are normally paid for through our Medicaid payment system. These were incentive payments to have providers and healthcare systems really begin to move on a path towards gauging their performance to reach clinical outcomes and other types of outcome measures, performance measures, in an overall move to value-based payment. So in order to do that, there needed to be some investment. These dollars really went to these systems to make these investments. But overall, again, to reduce the avoidable hospital use by 25% over 5 years, to increase collaboration across providers within a region, incentivize payments that are based on performance and outcomes, and in the beginning of this system transformation on process outcomes. And ultimately, at the end of our 5 years, our goal is to transition Medicaid payments away from fee-for-service, which really rewards volume, to those that are geared towards, value-based payment, meaning clinical outcomes and other types of performance measures. So on our next slide is really describing to you what our approach is, that in order to achieve this healthcare transformation, what New York did was set up a process of identifying and awarding 25 performing provider systems. The performing provider systems you'll see here, needed to include providers across a spectrum and a continuum of care in a community. You'll see there in that second bullet really about hospitals, PCPs, health homes, nursing homes, clinics, behavioral health providers, community-based organizations, home care agencies. And the responsibilities of this entity, this collaborative of all these providers in a community representing the spectrum, really was to together look at what the community healthcare needs were in that area, really identify then what particular types of projects should be engaged in order to meet the community needs and help move this overall needle towards reduction in avoidable hospital use. And really, the key element here was that this was a local collaboration, local partners working together to really get into the very meaty ground level game of how do we improve care for our community residents, our fellow community members, and what's working, what's not working, and really sit around a table for that discussion. And I think that is one of the hallmarks of the New York DSRIP program, has been that those local partnerships. And I think in many areas that I visited, clearly one of the messages is, we all work together in a community, but we had not talked to each other before. And I think DSRIP really brought that together. And I think what you'll be hearing really from both Tracy and Bill is because this was very focused at the local level, they were able to identify needs in their communities, meet those needs in a very nimble fashion and a very targeted fashion, and be able to, again, get resources in place, for the immediate term as well as for the long term. And just to show you where the 25 PPSs and where Tracy and Bill are from, NCI, which is where Tracy Leonard is from, is the northernmost dot on this map near the Canadian border. That is Lake Ontario that they are close to. And then in the circle there, Staten Island. Bill is from Staten Island. He is in that circle at the Staten Island PPS. And you can see how big and diverse New York State is. We have lots of very rural areas as well as the major urban centers, and of course New York City. So our New York DSRIP program was very comprehensive. It covered so many facets. I think one of the key goals here was really around how do we integrate health systems at a local level, and as well as then improving clinical care, in specific chronic care conditions, and then how do we really engage in the overall public health aspects for our communities as well. But but then there was particular focus in key areas. One of the key areas of focus was workforce, because as we think about this 5-year demonstration and transforming healthcare, what does that transformation look like? Where do we think we need to be in 5 years in order to really effectuate the kind of transformation we're talking about to make a difference and move that needle on avoidable hospital admissions? But to do that then also is, what does the workforce need to look like? So what is it that we think the workforce will look like given the vision of the healthcare transformation? So each PPS was asked to, as part of their application process, begin to look at, to really begin to, review what that would be, and they had to answer the questions that are listed up on this slide. And a key part of this is, we saw before about the community needs assessment, and then therefore, what is the, workforce strategy each PPS had to identify their overall workforce strategy. And you can see here is really, what anticipated impact DSRIP would have on the workforce, how existing workers would be impacted, a plan to minimize workforce impact, workforce shortages, and the percent of employees that would be impacted by redeployment, retraining, and new hires. I would kind of focus on, again, the whole idea here was strategy, and so we saw some PPSs really engage in, well, I would say some PPSs like Tracy had a workforce vision and strategy already, and then folks like Bill really took advantage of various his own professional experience, and then understanding his community and really engaging in going forth in lots of programs that he'll describe. Others went through a whole needs assessment simulation around their workforce. And I think that one of the key things that I would point out here is that in the application process, the PPSs were asked to identify, what do you think that workforce of the future looks like? What are the positions? So we saw a lot of the traditional ones of primary care, need for primary care, need for psychiatrists, psychologists, and then there was this other category, and it was a huge numbers in that other category. And as we dove down into that, really a lot of that had to do with non-traditional job titles such as care coordinators, care managers, navigators, community health workers, peer advocates. And so that is an area that we've seen. We are now in the approaching the 5th year, the last year of the demonstration. We've seen tremendous activity in this area that really is about how we transform the system from one that's been very inpatient-based to one that is more ambulatory-based and community-based. So that is kind of a DSRIP with the workforce view as in a nutshell. And, with that overview, I'll now turn it over to my colleague, Tracy Leonard from the North Country Initiative, which was that northernmost dot in the map.
Thank you for the opportunity to speak with you today. It's an honor and privilege to share our story with you, and we hope that you can take and apply some of our learnings. As mentioned, my name is Tracy Leonard. I'm the workforce lead for the North Country Initiative, our region's performing provider system, but I'm also the deputy director of the Fort Drum Regional Health Planning Organization. We are the foundational organization that staffs the NCI Project Management Office. So for the sake of time, I'm going to jump right in with a little bit of background about who we are, where we are, and what it is that we're doing. So when we say that we are from New York, we always have to remind people that we're not from the city. We're about an hour away from the Canadian border and about 2 hours from the Adirondack Mountains. Our region is very rural, and we're oftentimes known as upstate or northern New York, or we like to say the region that has more cows than people. We are proudly the home of the 10th Mountain Division, the most deployed unit in the United States Army. And I'd also like to note that Fort Drum is the only Army installation with a division of soldiers that does not have a hospital on base. They do provide some inpatient services, or they do not have inpatient services or an emergency room, but they do provide primary care and some ancillary services. I share this with you because it uniquely positions us to provide care in the community, not only for our civilian population, but for the active duty and their families. So in all that we do as a regional health planning organization, we must be thinking about the services that we provide for our civilian population, but also for our Army family. Our ability to provide high-quality, efficient care ultimately impacts the readiness of the men and women who serve and defend our country. In addition to the uniqueness of the integrated community military model, our region is federally designated a health professional shortage area. The population as a whole is older, poorer, more likely to be uninsured or underinsured, and sicker compared to our urban counterparts. And these factors can be easily exacerbated by the fact that we have a disproportionate number of providers to people, thus making access to care a challenge. Furthermore, recruitment and retention to a rural community with severe winters also strains our delivery system. So given this context, perhaps you now recognize the importance of an organization such as ours that came into existence in 2005 as a pilot program under Congressman then John McHugh. The military was interested in exploring how we plan and position ourselves to support the growth and addition of another brigade. We exceeded all deliverables of the pilot program in 2005 and demonstrated the value of our existence. So as a nonprofit today, we continue to serve as a neutral convener whose mission is to analyze the Tri-County system, identify gaps, and leverage resources to fill those gaps. We've been fortunate to be stewards of many local, state, and federal investments which have allowed us to do the work that we do. Again, we are in a unique position that we have been contracted by New York State to serve as a rural health network, a population health improvement program contractor, and, as Peggy noted, a district project management office for the PPS. We're also serving as a management service organization, a clinically integrated network, and an accountable care organization. So while each of those programs focuses on a different subset of the population or a different payer, because we are contracted to provide business, administrative, and technical services through all of these programs, we are able to approach regional planning in a holistic manner, regardless of payer, being good stewards of the funds received with a patient-centric focus. So shifting gears, I'd now like to talk to you a little bit about one of our focus areas, which is workforce development, with the program that actually began in 2008, well before the DSRIP program. This program aims to create a well-trained supply of healthcare professionals to meet the workforce needs now and into the future. While we need these qualified individuals yesterday, we have found that the greatest return on investment comes from when we grow our own through a long-term strategy, which ultimately begins with students who are in 7th and 8th grade, and then we follow them through this pipeline all the way up to employment in the field. The infrastructure that we have created back in 2008 up until now has created a focus on recruitment, retention, education, and training. It also focuses on career exploration, creating awareness of opportunities right here in our own community, student and candidate and employer connections, academic partnerships, and ultimately economic development. So unlike some other communities or performing provider systems across the state, as Peggy noted, we had a head start on our workforce strategy because we already had the right people at the table. Meaningful dialogue and data-driven decision and planning was already taking place. We knew where our gaps were and we knew where our resources were. Programs were developed and being implemented, and there was buy-in from all stakeholders. The DSRIP program, however, has been an incredible source of support that not only connected us to other workforce subject matter experts across the state, but it did provide us funds to help us tackle some high-need areas of our strategy that would not have been possible otherwise. So this slide aims to highlight a few of the initiatives that we focused on through our PPS. The first one, leveraging the long-term pipeline. We start early with students in our community because research shows us that if you're from a rural community, you're more likely to stay there. So we prioritize those who live, grow, and play here because it's proven to work, and you will see in the upcoming slides some examples of that. Secondly, we collaborate with institutions of higher education in order that bachelor's and master's level programs are available to members of our community. Programs are identified based on data and employer needs. Our role has been to provide a table for discussion for partners, to market and recruit for the programs, and then to monitor the market so that we don't flood it. So for example, we brought a respiratory therapy program in the past. We graduated 6 students and we flooded the market. These programs have and continue to meet some critical needs in our community. Thirdly, through the DSRIP program, we have been able to develop interdisciplinary teams through partner subcontracts. For example, the DSRIP dollars were used to train and certify certified diabetes educators. These CDEs were then contracted to provide services to our region's primary care offices. Furthermore, we are hosting monthly care collaboratives which allow partners from various entity types across the continuum to network, to receive education, to share de-identified case studies, and to respond to a call to action. We also recognize the need to train or retrain professionals on topics related to healthcare transformation. So we develop customized training videos that have not only been used by our PPS partners, but also shared with other PPSs and even with somebody in India. We have also adopted a train-the-trainer model to ensure the sustainability of these investments. And finally, we've been working with our local hospital who currently offers an MD and DO, graduate medical education and residency program. We're working to expand this program to other regional facilities who could not feasibly undertake this endeavor independently. One of the greatest workforce successes of our PPS was the development of incentive programs. Again, these incentive programs were developed based on data and identified community need. The incentive programs were made available to the PPS partners and aimed to provide funding to partners who needed assistance with the recruitment and retention of high-need professionals. In some cases, these incentive programs helped with the growth of professionals who needed additional training, education, or supervision in order to meet the licensure requirements of their profession. As you can see from the chart, identified areas of need included certified diabetes educators, licensed masters and clinical social workers, physician and physician extenders, nurse instructors, and clinical nurse professionals across different levels of nursing. Funds were made available for options such as sign-on bonus, salary guarantee, relocation expenses, loan forgiveness, etc. Service commitments by these professionals were made in exchange for this financial support. Each program had slightly different eligibility criteria, but each had the same ultimate purpose, and that was to build a workforce to meet the needs of the community. The next couple of slides will help depict the importance and impact of these initiatives. So first, I'd like you to meet Dr. Chang. Dr. Chang returned to our region to help meet a critical need. Data showed us that a regional proportion of third graders with untreated tooth decay far exceeded the statewide measure. Overall, our region was about 40%, and the statewide average was 24%. ED visits, or emergency department visits, increased significantly over the past several years, and this was associated with dental caries, which resulted in full mouth extractions for third graders. These conditions are exacerbated, again, by the shortage of dental and primary care provider shortages in the region. In particular, in Lewis County, one of our counties, it had been 5 years since Medicaid beneficiaries had access to dental services. Because of the DSRIP dollars, Dr. Chang is now serving as a dentist who accepts Medicaid in Lewis County. Also meet Dr. Katie McHugh, who ironically was one of our job shadow students when she first entered medical school. She is now serving as a primary care provider at an independent clinic in our region. Katie is a true example of how the long-term pipeline can work. Here you will also see some faces of success. Danielle DiBona was a high school job shadow student in 2010 and is now a physician assistant at one of our local primary care offices. And Jillian Young, a 2009 high school job shadow student, participated in SUNY Upstate's Family Nurse Practitioner program here at our community college and is now a family nurse practitioner at one of our local facilities. Both Jill and Danielle are great examples of how our region has leveraged career exploration programs, academic partnerships, and employer connections to recruit and retain homegrown students. In conclusion, I'd like to share with you just a few takeaways that I have learned based on my experiences with workforce development. So the first one is healthcare is not for everyone. Even if students recognize that healthcare is not for them, we consider that a win, because finding and applying your passion appropriately will only enhance the outcome for everyone. Recruiting from a rural region and growing your own has resulted in better retention. We find that the familiarity and interest in giving back to a community which has given to them has proven to be the most successful. Number 3, not everything needs to be sustained. We do know that some program initiatives have started and then left based on community need and with consistent evaluation of those efforts. It's okay to let things go if they don't work, and it's okay to hand things off to someone else when it's appropriate time and the appropriate partner. Number 4, about data. We find that data definitely helps drive decisions, but when it comes to the long-term pipeline, we have found that following and capturing data on students can be difficult because their phone numbers, their email addresses, and their mailing addresses change frequently. We continue to work with partners like our area health education centers to identify an effective strategy to do that. Number 5, relationships are key. A cup of coffee, a congratulations card on a white coat ceremony, or even an email to check in can go a long way. In fact, this summer, I'm invited to the wedding of one of our past job shadow students. Collaboration with academic institutions is critical. Without this piece of the puzzle, our employers would struggle with an adequate supply of future professionals. Furthermore, partnerships between community colleges and four-year institutions reduces overhead costs, improves student completion rates, and decreases regional vacancy rates. Number 7 is it's okay to be innovative. Don't be afraid to try something. If you wait for perfection, you'll never do anything. It's important to learn from your mistakes, to celebrate those short-term wins, and to have fun. And finally, building a pipeline takes time, but the fruits of your labor will be plentiful. I can tell you that a long-term pipeline requires a lot of patience, but as you can see from these slides, it is definitely worth it. So again, thank you for the opportunity to share our story, and with that, I will turn it over to Bill.
Okay, next up we have Bill Meyer from the Staten Island PPS, and Bill is going to tell us about a CNA registered apprenticeship program they began with their district funding. Hi, Bill, how are you doing?
Good afternoon. Doing very well, David. Thank you for having me.
Oh, we really appreciate it. Now, my understanding is that this program is the first of its kind in New York State. Can you give us a brief overview?
Sure. One of the issues that many of our partner employers face are recruitment and turnover problems. And we have 10 large nursing homes, 2 hospitals, 3 federally qualified health centers, and 54 community-based partners that make up our service area here. We've got more than 12,500 employees in this network. And when we talk to partners about recruitment and turnover, they were trying to figure out ways to expand the pipeline. And this whole idea of apprentice learning is starting to take hold in healthcare. Our nursing homes sat down with us and we said, how can we expand the pipeline? So we came up with the idea of this federally registered apprentice program.
Thank you, Bill. And, you know, you mentioned about turnover in healthcare being a real problem. And can you talk a little bit more specifically about, like, how your CNA registered apprentice program addresses this challenge?
Sure. What we did with the whole apprentice program was to sit down with the partners, with the unions, with higher education, and with our best frontline CNAs, the existing incumbents. And we said to them, tell us from your perspective, what are some of the drivers for this turnover? And issues that kept coming back were people were coming into the organizations being hired. They were lacking in many soft skills like motivational interviewing, conflict resolution, team-based care. And when you think about it, physicians and nurses have to serve an apprenticeship. The doctors have a residency, nurses have preceptor programs. So the top leaders, the top clinicians in healthcare already serve an apprentice program. Our partners said to us, we think our frontline people should get the same type of learning before they interact with patients and families, because many points of conflict and misunderstanding happen between the frontline healthcare worker and the patients and caregivers and families and friends. So, you know, it was the lack of skills coming into the job, and that lack of skill then created a need for the employers to retrain their new hires. And when they're retraining new hires, it takes longer for them to go from the point of hire to actually providing services on the unit. And that length of time then creates mandatory overtime. Mandatory overtime is actually an avoidable cost for the employers, and mandatory overtime also has negative impact on employee relations and employee morale.
Okay. A little bit more on the types of skills. Could you say something about the specific types of skills that have been identified as key to this new learning?
Sure. Motivational interviewing, which not only here in Staten Island, but when I talk to my colleagues across the state at all PPSs, the one greatest skill training that we have provided for all the employees across New York State has been motivational interviewing, getting patients and family members to communicate and getting them to the point of saying yes to creating change in different types and aspects of care. The second biggest piece is team conflict and resolving team conflict. The third is, to understand what's going on with the patient. We use Interact, and it's specific training to tell staff members from the housekeeper all the way up, when you notice a change in a patient, whether it's their speech, their mood, their affect, if it's their clothing or how their gait and everything else, to say something, to teach everybody on the care team, no matter what your job, if you see a change in a patient, we encourage people to speak up and say something. It also goes to the nursing homes. We have a sepsis challenge, and we did a sepsis training program. And one of the things about apprentice learning and training from DSRIP, we are finding best-in-class training. And if we do a training class, let's take motivational interviewing or let's take care management. In that class, we will have people from 8 to 15 different organizations learning the same best approach. They go back to their organizations and they spread this best-in-class learning. So instead of the old approach where every organization designed its own training and they were operating in a silo, they now come together, learn best-in-class, teach each other through communication, go back and spread this best-in-class learning across multiple organizations. So we create best-in-class learning, and we start to break down the old silo approach to training. And another benefit to this is that when these people from organizations come together, they know one another, they start trading names and phone numbers, and they have a dialogue in these training classes, and they talk about operational issues, and they teach each other how to figure out ways to overcome challenges, and when they leave the training, they also still stay in touch with one another. And another piece of this, too, is when we sat down with the incumbent nursing assistants to help redesign this curriculum, many of them said, this is the first time in my entire career that someone asked my opinion. And I feel honored and I feel empowered. And they are becoming the mentors now in this training program, because part of the apprentice learning is earning and learning. And when you start the apprentice program, it's a combination of classroom and on-the-job learning. And you're being mentored by the best CNAs. Those mentors are the people who helped us redesign the curriculum, which we submitted to the Department of Labor, who signed off on it, and that is how you achieve your federal certification. It is a certification that is recognized in all 50 states. And there's federal funding that actually pays for the classroom portion of this.
Okay, that's actually fascinating, Bill. Now, has the initial launch of the Registered Apprentice Program for certified nursing assistants led to further interest?
Yeah, good question, and the short answer is yes. We have 2 large nursing homes involved. We have 2 other nursing homes that want to come online in June for CNA, but they're also already looking ahead, and they want to do an apprentice program for cook, an apprentice program for LPN, and some other organizations are talking about pharmacy tech. And again, it's an idea to step back and say, looking at our job descriptions, when is the last time we actually changed them? When is the last time we looked at the skills required? Are they still relevant today? With healthcare changing as rapidly as it is, many employers said, we have not looked at our job descriptions in years. So when you don't change a job description, but the job has changed, you're advertising a set of skills that may not be completely relevant. And when you recruit based on a worn-out set of skills, you're going to bring someone into the job who's not equipped to really meet the demands of the new healthcare landscape. So that is what's driving this whole thinking about apprentice learning, is to say, this all makes sense. We need to take a step back, look at the skills we're requiring, look at the way we're recruiting based on these skills, and internally say, do these skills still make sense, or do we need to reskill, reissue the skills, and retrain the workforce that's not only incumbent, but it's out there. And another piece of the apprentice program is that once these apprentices finish their program, we're going to take those additional skills that they have learned. We're going to use those skills to teach the incumbent workers in these organizations, these same skills. So we started with the apprentices, and then we're going to germinate the incumbent employee population with the same set of new skills, so that this is organization-wide.
All right, thank you. Now, perhaps we can talk a little bit more about how did you define the on-the-job and classroom learning aspects of the program? What partners were involved in this, and what's the balance of in-classroom work versus on-the-job training?
We started with, of course, the state mandated requirements for the certified nursing assistant, and we went through each piece of that learning, and we said, again, to the staffers, you know, what is missing here? And we built in, and we brought in the curriculum designers from the College of Staten Island, which is part of the CUNY City University of New York system. We brought in their curriculum developers to actually help us tailor and write the curriculum. That was part of that. And organized labor is also a very important partner of ours, Local 1199 SEIU Training and Education Fund. They helped us with the employee education, with the delegate involvement, and we also had the leadership and the educators from the organizations. Everybody in the same room rebuilding this and going piece by piece, and the curriculum writers helping us to write out and design the curriculum that ultimately became submitted to the federal government.
Okay, thank you once more. What has been the initial feedback you have received from both the classroom and the on-the-job training for the apprentice learners?
We do a weekly touch point with all of our partners, which again is the employers, the unions, and higher education, and we look at outcomes. And every student, we're into week 9 of our process now. It's a 6-month process. Every student has achieved a score of 80 or better on their exams. And we also hear from the mentors who are coming back and saying, as we teach this now to these apprentices, we are seeing ourselves the value of what this is going to bring to this organization in terms of increased skills and increased confidence. We think we're going to have, and we feel we're going to have, a better trained CNA, a more confident CNA, and we can't wait to use these skills and teach our colleagues here. So it's creating this momentum here in Staten Island. That is what is driving the 2 other nursing homes to get involved in this process as well. And like I said, the test scores are bearing out the success here. And in our weekly touch point calls, the partners and the unions are very happy with this process. Some of the union leadership have remarked that this looks like the way to the future for the union, is to train a lot of their members who are apprentice learning going forward.
Okay. And has this program created a new hiring pipeline, would you say? Does it offer upward mobility?
Yes, good point. More than half of our new hires were former home health aides, and they are going from $10 an hour jobs to $17 an hour jobs at the completion of this process. So the apprentice process, they start at $15. At the midpoint, they go to $16. The end of the program, they go to the job rate, which is $17, which is in our collective bargaining agreement. So this has created for that entire home health aide universe a career ladder up. It was also offered to internal staff, but the greatest influxes have been home health aides. So we now have this new pipeline, this entire universe of home health aides who can now move up the ladder through the CNA Registered Apprentice Program, and then we do CNA, which becomes CNA to LPN. We can do pharmacy techs. So we're going to continue to build out this career ladder and use the apprentice learning.
That sounds good. Now, we're actually already at around the 41-minute mark past the hour, so I'm going to ask one more question of you, Bill, and then we'll open it up for audience Q&A session. One more question, and I actually have others here too, but I'm going to leave it to one for now. Are there other job titles being considered for registered apprentice learning that you're aware of?
Like I said earlier, we're looking at cook, we're looking at LPN, we might do pharmacy tech, and the universe is pretty wide open for this to take off here.
Good. Yeah, I think that's a good way to wrap up this section. Once more, thank you, Bill. Let's go ahead and begin the Q&A session with the audience. Once more, for those of you out there, if you have a question, feel free to use your chat panel to ask it. And with that said, I do have a couple questions here myself. One of them, I think perhaps, Peggy, perhaps you could address it. My understanding, and correct me if I'm wrong, there is kind of an evaluation component to the DSRIP program as a whole. One, is this the case? And two, how do you manage it given that there's, 25 separate PPSs?
There is an evaluation component. The evaluation is actually part of our terms and conditions with CMS. So we were required to, find an independent evaluator and have an evaluation design scoped out and approved by CMS that really has to do with the overall effectiveness of the program, looking at so there's a lot of data. Again, we are one of the things about our demonstration is that it's performance-based, so that the PPSs and the state basically have to earn the dollars. So while in the first couple of slides, I talked about how New York was able to come to an agreement with CMS for a reinvestment of the $6.4 billion of savings back into the Medicaid system. All that money has to be earned by the PPSs and the state collectively. And if we actually do not meet various performance measures at a certain threshold statewide, there is actually a take back. So because of this performance-based model, there's a lot of data that's being collected, so the evaluation design is really being looked at based on that data, as well as a qualitative component, and that is surveying PPS provider partners and others to help fill that out. But again, this is a very data-driven demonstration, and so the evaluation design is also very data-driven. And it will look at improvements in clinical outcomes and whether we've met the target of avoiding reducing our avoidable admissions by 25%. And the preliminary reports, your progress reports show that we are pretty much on target, which is good news.
All right, thank you, Peggy. And Tracy, the next question's for you. Other than the rural nature of your community, what has been one of the biggest barriers with recruitment?
Yeah, so that's a great question. One of the things, I talked about the uniqueness of our integrated model with Fort Drum, and New York State has a very high quality educational standards and requirements, but one of our challenges has been licensure reciprocity. So because of the Fort Drum population, we have a lot of qualified candidates coming into our region from outside of the state. And because we are the most deployed unit, those soldiers and family members are oftentimes here for a year or two at a time, and then they leave. So we have gaps in our employment facilities, and we have qualified candidates in our backyard, but we're unable to hire them because of the licensure reciprocity challenges. We have done a bit of advocacy around that, and we want to ensure, obviously, that the quality and standards remain strong and that New York State can generally be transferred to other states. But for us, it's been very difficult where we have qualified candidates and we have job openings, but we're unable to leverage that resource.
Thank you, Tracy. Now, Bill, back to you. We've already actually covered quite a bit of ground with your discussion of the CNA Registered Apprentice Program. With that said, is there any other final thoughts you'd like to let the audience know about the program or that you'd like to share with them?
Sure. The program, as I see it, is a maturation of our whole transformation process. We started early with a partner survey like Tracy, and we identified their training gaps. And through that training gap analysis, we provided more than 35,000 hours to more than 12,000 healthcare employees, skills training to more than 54 partners. And those are half-day to two-day sessions, and Interact is a lot more detailed. But as we started gaining traction and doing the training, we also then developed scholarship programs with the college for students from low-income families those students were working towards master's degrees in social work and mental health counseling. Those were identified as gaps in our workforce. And we just recently graduated 21 students. 18 of those 21 scholarship students are now working for partners. So we went from training to scholarship development. We then worked with the college to develop a master's in healthcare administration. We also developed adult certificate programs on community health worker, care management, peer recovery. Some of our adult programs are straight certificate, others are with college credit. Our first HW class had 11 students. The following fall, 3 of those 11 enrolled in the college to pursue degrees. So we've gone from training to training with college credits to scholarships. And then the next logical step here was to actually take an entire job apart and rebuild a curriculum and getting all these partners to the table to train a new class of workers coming in and to create new hiring pipelines. So to us, this has been a natural step up in changing the way we train, hire, recruit, and retain workers here in Staten Island.
Thank you, Bill. I mean, that's really an interesting program you have going there. Let's wrap up this event by Peggy, Tracy, I'd kind of like to ask y'all the same question. Do you have any final thoughts about today's event that you'd like to share with the audience?
I would just say from the New York State perspective, I think workforce leads like Tracy and Bill have just shown what incredible, I think, creativity and dedication and looking at, what is needed in their community and coming up with the innovative types of programs and the hard work and working with all the partners to try to figure out how to best do this. And I think, as I kind of said in the beginning, that really the success of the DSRIP program really has to do with meeting local need and doing local problem solving and the nimbleness, again, of people like Tracy and Bill as far as, seeking out those partnerships with academic institutions, looking at what are the types of programs that will be effective, really talking to their partners around the different dimensions that need to be addressed, such as, how do we recruit, but then how do we retain, and what other needs are there? How do we, build those career ladders? I think all again, the great creativity and innovation, by the 25 PPSs.
Thank you, Peggy. Tracy, do you have anything to share?
Yeah, it's just to kind of reiterate a couple of the points that I made, and one is that I think data is very, very important in the decision-making process of how you will use the resources that are provided to you. Data is the infrastructure that allows us and allows everyone else across the state to be good stewards of the funds that have been reinvested into the state. So as much as the data is so incredibly important, I think the relationships that you develop with partners, with students, with institutions speaks volumes. And that's not, I think sometimes we have some big players in the sandbox, such as our hospitals, but I think it's so critically important that the work of the DSRIP program needs to be across the entire care continuum, from pre-hospital care with emergency medical services at the table, with your behavioral health partners, with your federally qualified health centers, you name it. I think it needs to be the entire continuum of care, and we cannot let one single partner drive the agenda. It has worked very well for us to be the neutral convener and the neutral table for discussions. So I think those relationships and the data is what ultimately allows us to be good stewards of funds, and hopefully what will allow New York State to receive additional federal funds in the future. So we cannot thank the state enough for entrusting us with using those funds accordingly, and we look forward to, sharing the value of the work that we've done so that we can share those best practices across other parts of the state or even in other states.
Okay, thank you, Tracy. And at this point in time, I guess we'll go ahead and end our event today. But once more, thank you, Peggy, Tracy, and Bill for participating. I thought it was absolutely interesting. And thank you for attending in our audience. We always appreciate you coming out to our events. With that said, we hope to see you again in the future. Have a good afternoon.
Just to let you know, we will be posting our slides shortly to our website. So if you want to download them, check back very quickly at healthworkforceta.org.